So thank you all for coming. My name is Deborah Ruddy, and I'm a clinical geneticist at Guy's. And I'm also the clinical director of the Genomic Medicine Service, which is based at Guy's but covers all of South East England. And we have put together this teaching session to go over the changes that are being made to the National Genomics Test Directory as of the 1st of April. And the point of today's session is so that you get to know us and realise that you can contact us at any time if you've got any questions, so that you can meet Carolina, who's one of our senior scientists, who is going to talk you through the changes. And also, I think it's very useful for you as clinicians to meet a scientist and have a feel for what her job involves after you've filled in a form and taken a blood sample from a patient. We've also got Nikki here, who's our communications guru, who sends out most of our comms. Thank you, Nikki. And I'm just having a quick look to see if we've got any Evelina paediatricians. If you're an Evelina paediatrician, can you make yourself known? No. Okay, so let's get started. We'll have some slides from Carolina, which will be, as I say, explaining the changes to the test directory that will come into force after the 1st of April, and then we'll have plenty of time for questions. So Carolina, over to you.
Okay, thank you very much.
You're muted, Carolina.
Okay, can you hear me now? Okay, welcome everyone. My name is Karolina Pawliczak, and I am the lead scientist, clinical scientist at Synovis, responsible for the whole genome sequencing for rare disorders. Oops. Okay, so here we've got a screenshot of the current test directory, which lists all the tests available which are provided by Genomics Lab across the country. Currently, we are on a version 8.1, which was released July last year. And in April, we'll be moving to version 9. In the test directory, you will find all the eligibility criteria which your patients must meet before you can order the test, as well as requesting specialities. So I will talk you through the test directory changes, and I will focus only on tests which are provided by whole genome sequencing service. So I will not include any other changes. So we've got two main groups. So the first one is focused on the so-called core tests, and this applies to R21, intellectual disability, until now provided by whole genome sequencing, R377, which is another test for intellectual disability, but provided by microarray. And lastly, R59, which is the early onset syndromic epilepsy panel. So all those tests will be retired, and from April, patients who meet eligibility criteria will be able to should be able to be tested on R27 pediatric disorders panel. The other group of changes are related to neurology panels. So in the first instance, R58, which is the adult onset neurodegenerative disorder panel, will be retired and will be replaced by 4 new clinical indications. And lastly, we will be introducing one super panel for neurological disorders. And I will take you through the changes in more details. So R27 panel, which will be for replacing R29, R59, and 377 tests. So the test criteria for this panel have been updated. We include now epilepsy referrals, And in the past, we used to prioritize analysis, submission and analysis for patients with refractory epilepsy, and we will continue to do so. So please indicate if this is there is a need for prioritization. Please indicate this on a test order form when you request testing. The next change is, as I mentioned, is the R58, adult onset neurodegenerative disorders, and this panel will be replaced by 4 new clinical indications, which are listed here. And until now, we've been testing patients eligible for tofersen under R58, and those patients were prioritized. And again, we'll continue to do so. So if you request R60 for ALS patients, please tick the urgent box and add comment about tofersen eligibility. And the last change, this is related to the new super panel related to adult onset neurological disorders. It will cover 7 neurological clinical indications, so 7 panels, and these are R54, R56, R60, and the 4 new clinical indications which were previously covered by R58. We still don't know what the R number will be for the panel, and we'll confirm as soon as possible. So we don't have the number at this moment yet. Briefly now, I will talk how to order WGS and what's the process of requesting the testing. So this is a screenshot of our website, which is southeastgenomics.nhs.uk. At the top, you can find a tab where you can find information on all tests provided by our lab. If you search for a particular test, you will find all the information, which forms are required, what's the sample requirements. So you have all the information there. In terms of the forms, we require whole WGS test order form, and this is different from than non-WGS. So as always, you've got patients identifiers here. This is the priority box for urgent referrals, and also you've got a box to include all family members who will be tested. So if you're requesting a trio analysis, then please indicate here that please provide parental details in this box. On the second page, we've got a table for HPO terms, and my plea as a clinical scientist, please provide as many HPO terms as possible, because this is our way of analysis is very helpful, and analysis is guided by it's phenotype driven. Just to highlight also that we don't have access to EPIC, so we don't have access to clinical notes, clinical letters, so we only rely on the information you provide us on the form. The second type of form which is required is the record of discussion, and this form is required. We require 1 form for each family member. So if it's trio, we need 3 forms for each of them. When you consent your patients, please remember that there is a risk of uncertain results. Occasionally, we report class 3 variants, which are all of uncertain clinical significance. These variants, we would only report if there is really strong suspicion that they might be causative, but at this stage, there is not enough evidence to classify those variants as pathogenic or likely pathogenic. But I think but we could potentially revisit those in the future. Please also remember about the risk of unexpected results and incidental findings. So as a part of our analysis, To exclude a sample mix-up, we perform family relationship check. As well, we can also detect incidental findings related to either cancer predisposition genes, cardiac genes. We don't actively look for those variants, but there is a chance that we might detect them. And this can also apply to all family members, not just the proband. And lastly, this is the blood form. Basically, this is our non-WGS form. You can use it as a blood form for your patients to take to the phlebotomy to have the bloods taken. So if we've got, in a summary, we've got kind of 7 steps for success. When you make a referral for WGS, please aim for TRIO, especially for pediatric cases, if possible. Please arrange for the correct sample, then fill in the forms electronically. Please remember to include all the information like ethnicity, HPO terms. Then please remember about the record of discussion. Again, we need one for each family member. Then test order form and send it to our WGS team, which is send it to gst.wgs@nhs.net. And if all the forms are correct and we've got all the samples, our WGS team will send you an email with a confirmation when the sample is scheduled for submission and processing. If there are any problems with either with the forms or with the sample, again, you will hear from our team how to resolve and proceed with processing. Here I've listed the most common errors that we're coming across. Unfortunately, they're leading to delays. So please remember, so all the errors I've divided into groups. So the first errors are related to the pre-submission process. Usually they are related to missing information on the test order form or record of discussion. As I mentioned, ethnicity, NHS number, panels. Another main missing information is HPO tells. So please remember that we heavily rely on this information. And lastly, frequently we see absent signatures from either patient or healthcare professional. Please also remember to follow the correct referral pathway, so please send the forms to gst.wgs@nhs.net email account. The second group of errors is related to post-submission process. So we've started already processing the samples, and the analysis pipeline detects some unusual findings, and most of the time they are related to undisclosed information. So as I've mentioned, we check for the family relationship, so any non-paternity, non-maternity will be detected. We may also see patients who underwent bone marrow transplant, or we can pick up some inconsistency in sex if it's not as expected. So we can't really progress with the analysis until those errors are resolved. So we'll be if this happens to one of your patients, then we'll be in touch how we can resolve the issue. As I mentioned, we advocate for TRIO analysis because it's more powerful than singleton. It increases the chance of diagnosis for your patient. If we don't find pathogenic variant, causative variant in applied panels, we do additional check. We check for the novel variants, and this is only possible if we've got parents. And it also decreases the chance of uncertain results because, again, we've got the inheritance information, so we can see whether the variant has been inherited from either similarly affected parent or from unaffected parent. And lastly, it is quicker analysis for us. It's easier, therefore we can provide quicker turnaround time for your patients. Very briefly, I will talk about data analysis. So because it is called WGA whole genome sequencing. However, we apply virtual gene panels. We only will be testing for green genes listed on panel app, so we don't screen the whole genome. In terms of region of interest, we only focus mainly on exonic sequence, and we would include known intronic pathogenic variants. We cover all variant types, so we will cover single nucleotide variants. We also cover copy number variants, so therefore there is no need for additional testing by array. And also WGS covers short tandem repeats. And the most common one, especially for pediatric patients, is the Fragile X. So there is no need for additional testing once you've got your negative reports from WGS. And this is my last slide on data analysis. So if we don't find any causative variant cleared by our pipeline, we do additional checks. So as I mentioned already, we check for de novo variants, and this is only possible for trio analysis. And those variants can be either from the pipeline or outside from the applied panels. And we also check for, we also use a tool called Exomizer, which is a variant ranking tool. It uses different prediction tools, allele frequency. It refers different databases and gives us a probability score of a variant being pathogenic. So because those two extra checks are performed to increase the diagnostically, but also there is a risk of incidental findings because we're looking for variants we might be looking for variants outside of applied panels. So in summary, when you refer patient for WGS, please refer to test directory, check eligibility criteria, fill in test order form, record of discussion correctly. Please remember that trio analysis is more powerful than singleton, and please remember that there is a risk of incidental and unexpected findings. So that was my last slide. I've put here contact details in case you want to contact us, and we'll be happy to take some questions.
Can you show the previous slide, please?
With the contact details? This one?
Thank you.
Thanks, Carolina. That was really helpful. I know Luigi's got a question, but just to emphasize that because of these changes in the test directory, what I would suggest is that before you request a test on one of your patients, you double check the test directory, even if it's a test you've requested thousands of times before. After the 1st of April, please double check and make sure that your patient is still eligible and you've got the correct R number to write on the form. Luigi.
Hi, I'm Luigi D'Agenzio. I'm a pediatric neurology consultant at St. George's Hospital. A question about the new the panel that are being dismissed, and obviously about the epilepsy panel, because that's the one that we probably request most. A few times, so first of all, the ones that are currently in lab and are being sequenced, after this they will be automatically changed to R27, or or they will still go by R59. What I'm asking is, do you already add the extra panel for R27 or the extra genes for R27 or not? Because I have
the answer is no. So
okay.
R27 is a whole genome sequencing test, which obviously comes associated with whole genome sequencing forms, whereas the R59 test is a panel test.
That's
Is that true, Carolina?
no, that R59 is
sorry.
WGS.
Sorry, well, I'm talking nonsense then. Apologies, Luigi. Carolina, why don't you answer?
No, the R59 is it is already WGS, and now all those patients will be tested on the bigger panel.
Yeah.
So you'll do that automatically?
Yeah.
Okay. If the sample is already with us, we'll process in, on R27.
R27, perfect. And the second part of that question was because for previous sample, I had to request a reanalysis. I think is form R387 for reanalysis exactly for this reason. So patient that had an R59 negative WGS and with suspicious of possibly mitochondrial or other disorders, I had to request an R27. So again, I assume that if I'm now asking for this for patients that were previously analyzed on R59, then this will be acceptable?
All our reanalysis requests will be discussed at MDT, and we'll advise at the time that 59 is no longer available and will offer R27. So we can't really activate any reanalysis request without any discussion at MDT, just to make sure this is